I think what we've talked about a little bit today is trying to align on missions and goals. So ultimately, the connection here between each, even though these individuals represent very different organizations and not necessarily connected with one another, we all have in common these very specific goals to help more patients. And so really just wanted to spend this time focusing on how we're working together and sort of what are your ideas about partnering, about expanding, about being able to identify optimal ASOs and help more patients. So I'd like to start off with sort of a general question to each of you. Maybe Annalisa, we'll start with you. Oh, I forgot the introduction. Oh my gosh, sorry. So let me introduce the panelists. So first we have Annalisa. So Annalisa Taylor-Tavares, she's the clinical lead of rare disease research at Genomics England. So we're very pleased Annalisa came over last night, so really appreciate that. Kristen Stevenson is the director at St. Jude's newly formed sort of pediatric translational neuroscience initiative and treating pediatric patients with rare neurologic diseases and expanding and just helping many, many pediatric patients. We have Neil Shneider, who's really representing the Silence ALS Partnership. And so Neil is a clinician scientist at Columbia University. And I think a lot of you know Neil from the FUS ALS patient that we saw earlier from Stan, and also just a general great guy and leader in ALS. And Terry Jo Bichell, thank you so much, Terry Jo, for coming. She flew in this morning as well. Terry Jo is the CEO of COMBINEDBrain and a neuroscientist. I mean, this is an exceptional panel, right? And ultimately represents over 50 advocacy groups and here to really think about how can we work together to make those groups aware of what we can potentially offer. So now we'll get to the first question. So I think I just wanted to really touch on, given n-Lorem's a small organization, and we fully acknowledge we're doing everything we possibly can to increase our specific capacity. We're partnering. I think in the last panel we heard a lot of just amazing support that we're getting, how we can internally increase our capacity and continue to grow. And we acknowledge that we are one organization and we are small and we are limited on our resource. And so therefore, how are we really working with each of you? And what are your thoughts on how can we help more nano-rare patients together? So Annalisa, if we might start with you, kind of on your thoughts on that.
Yeah, well, thank you so much for having me. So I think the collaborative approach that you're taking is wonderful. And this is a global problem that everybody is trying to crack. And so we really need to work together globally. I thought maybe if I just explain a little bit that the system in the UK is obviously different with the national healthcare system. And Genomics England had helped with the 100,000 Genomes Project, which is a research project, but completely embedded in a national healthcare system. And now, within the NHS Genomic Medicine Service, a clinician can order a whole genome sequence and their patient can consent for that data to also be available to researchers. And crucially, we can then go back to the clinical teams if they find either a new diagnosis or if there's a potential therapeutic option. So for me, these kinds of opportunities where there's a hugely rich national genomic data set that could really, that comment earlier about you can always find more, I think is going to be really key to this. And I think ultimately, you'll treat a lot of patients, you'll pave the way, and actually also shift the thinking about how one treats rare disease. Because if there are, since the vast majority have such a low prevalence, it needs a completely transformative approach.
Great, thank you so much. Kristen, we'll turn to you.
Sure. So I think obviously, in addition to collaboration, which would be my number one suggestion as well, I think a lot of what n-Lorem is doing, for example, bringing this group together today is incredibly helpful. I think, helping identify what the collective voice is for this community, realizing there are many different realities based on the information we've just heard this morning and what we all know from our work. Having a collective voice is going to bring a lot more empowerment to this community and allow for easier policy change and allow us to really move into something that becomes much more scalable and realistic from a long-term perspective.
Yeah, Neil?
Well, first I'm very pleased to be participating in this and so grateful to n-Lorem for all that they've done for the ALS community. We heard, this morning about this extraordinary technology, extraordinary platform that Stan has built, and there's real need, as we've been saying, to build n-Lorem's internal resources. They are very good at doing what they do. And those of us who are patient-facing, can turn to n-Lorem with great trust in the quality of the procedures that lead to a clinical ASO, and that is really meaningful to us as clinicians and to our patients. They do many things well, but n-Lorem doesn't have direct access to patients. They cannot possibly be involved in every disease community in a way I think that is necessary for these programs to succeed. And I think that's where collaboration, important word, with clinician scientists really matters. We as clinician scientists, and I learned this from the FUS ASO program, working with Ionis and n-Lorem in the early days, that we have, as clinician scientists, the ability to push at the frontiers of these things, push regulatory policy, push the science of these things, and to do human experiments of the kind that Stan described in a way that are, I think scientifically very important, but also, lead to huge therapeutic advances. And so we need, as members of these, disease communities, to partner in the way that we have with Silence ALS, to partner with n-Lorem, to bring the resources of our specific disease communities to this effort, and to help the program to reach as many patients as possible and scale.
Yeah, thank you so much. And Terry Jo, I'd love to hear from you.
Well, I think that one of the most important things we can do right now is educate the whole world to realize that what we thought was uncurable before is curable, and so that we can actually normalize ASO treatments over time to the point that eventually we'll all get universal newborn sequencing. We'll all have our whole genomes sequenced. We'll early on know about specific gene mutations that we'll have, and we'll know that you'll have to take your ASO vitamin pill treatment at a certain point in life. We need to, knowing that these families and these disorders are the pioneers, like Stan said, this is going to be ushering in a whole new era. So I think that what we really have to do is educate doctors, patients, and the whole healthcare system to accept this as a new way of treating everything.
Yeah, it's a great point, and we'll talk about a little bit more today and this afternoon, but I think that's one of the key components is like, this is really and truly, it's a shift in our mindset about how we're thinking about healthcare, how we're thinking about drug discovery and development, and how we're thinking about collaborations and partnerships. So Annalisa, I'd love to come back to you. So Genomics England is world renowned for your 1,000 Genomes project, and really the genotype phenotype data that you've collected in this very robust manner, and now kind of thinking about that next step and moving towards therapeutics. I wonder if you could just touch a little bit more on some of the key challenges that you foresee and that you envision as we try to identify potential patients that you might have diagnosed that we already have ASOs for. What do you see as kind of some of the key next steps and challenges that we need to be tackling head on?
I think that's a really, really important question. I'll try to keep it brief because I think we could talk for a long time. And I think one of the key challenges is how we join up the ecosystem and how it really is truly a collaborative approach. And I think in the UK there's obviously the NHS, the MHRA, the regulatory body, and everybody, Genomics England, are all extremely committed to treating patients and getting the right treatments to patients. And so I think that commitment to the mission, I think, is amazing. And I think in a national system, if you get it right, and once you've got it right, you can then really run with it. Yeah. It can take time to get it right, because everybody is trying to get it right in a way that then is going to work in a scaled up national way. So it's a strength, and it's also really important to work with the whole ecosystem and bring everybody together.
Yeah.
I think I made a couple of notes just because I'm very jet lagged. So I wanted to mention, obviously, there was the mention of the newborn whole genome screening pilot that's starting. Again, that's truly working with the NHS. And I think the point earlier about innovating a care model is so important. And actually, so a lot of clinicians are naturally risk averse. At least a lot of the ones that I work with. And I think it's right to put patient safety first. And I think we have to do this in a way that builds confidence and sort of spearheading the way with the first few patients and working out that pathway with the whole ecosystem will then suddenly open the gates, I hope.
Yeah, it's a great point, and that's, I think even one of the questions that Stan answered this morning is, we already have identified a number. We have the 9 INDs, and we have many, many more coming behind. Do you have any individuals who could benefit immediately? And then the question is, how quickly and efficiently can we actually get that ASO to that patient? Can it be in a time that's meaningful for their disease prognosis? So thank you for that. Yeah, this is a really exciting sort of budding collaboration that we have started. So Kristen, would love to turn it to you, thinking a little bit about what St. Jude is doing. Can you share a bit about really what you want to do in this collaboration with n-Lorem and just kind of expand on what you're thinking of what this will look like in the future?
Sure. So for a little context, in 2020, St. Jude launched the Pediatric Translational Neuroscience Initiative, which is a very dedicated long-term focus on applying the infrastructure and the capabilities of the organization to translational neuroscience, so really addressing catastrophic pediatric neurological diseases. And as part of that process, we're really organized with a translational focus so that we have a preclinical area focus through our Center of Pediatric Neurological Disease Research. We have a clinical focus through our Center for Experimental Neurotherapeutics, and then the Office of Strategy and Alliances kind of helps tie those things together, which is the part of the organization that I'm involved with. And so as part of that strategy and alliances component, we're really actively looking at and considering folks across the stakeholder landscape that we might be able to work with to have synergies, collaborations. And n-Lorem, of course, came up very early and often in those conversations when we were looking at the landscape for this ultra-rare, nano-rare kind of community. And as we were thinking about what our genomics program that we've recently launched might look like, we wanted to see who all we could learn from, work with, collaborate with. And n-Lorem came, as I said, up in many conversations. And I think that with Stan Crook's experience and expertise in ASOs, which I think is quite evident to everyone here, and with your really unique process and model for identification all the way through IND filing, that was something that was very appealing to us to work together on, as well as the mission of n-Lorem and your nonprofit organizational structure.
Awesome. Well, thank you. I know we're really excited also about this collaboration. So Neil, when I turn to you, so I think, what we've established with Neil and with Columbia is we've called Silence ALS, that Neil sort of coined. And really the goal here is, as we know for all of our patients, is every day matters. Every hour matters, and we have to feel this urgency. I think when you meet all of us from n-Lorem, you probably get a sense we sort of operate the way Stan Crook does, right? So we're hurrying because we know, and we just appreciate meeting all the patients here this week. And so what we're trying to do is just then think operationally. So what can we do to work together? As Neil said, we don't interface with the patients. We're actually blinded to the patient's identity. And ultimately, how can we work with Neil very closely through his scientific and clinical expertise to be able to bring the patients to us so we can just hit the ground running? So I guess I wanted to just talk a little bit about your experience and kind of think about what have been the efficiencies that we've put in place, and maybe you could share a little bit about what we're doing now and where we're headed.
All right. So, Silence ALS really grew out of the FUS ASO experience. Again, it helped us to realize the power of this technology and the ability to help our patients. N of 1 turned into N of many for FUS ALS, and the ASO is now in commercial clinical trial sponsored by Ionis, but it's really at the cusp of commercial viability. Some might say it's below the cusp, but what it made us realize is that there were many ALS patients out there that could benefit from this. People who I think would never be included in a commercial effort. So ALS lends itself, I think, particularly well to this kind of an approach. It is a genetically complex disorder. It's an ultra-rare disease, but there are, within that, there are dozens of mutations, or hundreds really, of mutations in dozens of genes. But many of those genes are micro-rare, many are nano-rare. And so we needed an approach to ALS that was, I think, able to approach this complexity, genetic and phenotypic complexity of patients. And that was what I think Silence ALS is. It's an effort to pair n-Lorem's platform with expertise and infrastructure that already exists within the ALS community. It's a partnership with Columbia, but really, as this grows, this is going to involve ALS clinicians nationwide and hopefully not too long internationally. We need to identify these patients. We need to phenotypically characterize them. We need to follow asymptomatic carriers in advance of disease onset. We need to provide patient data, samples, disease-specific resources to n-Lorem to help them to do what they do so well. And so that is what we're trying to do with Silence. There is a wonderful active ALS community around the world, and we're tapping that for the benefit of Silence. There is a great opportunity not only to treat these nano-rare patients, but to collect them in a group. And as Stan was saying this morning, to do one case, you learn a lot. But to apply the same ASO to multiple patients with the same mutation, or to look at patients with the same gene mutation, same gene mutation, but different varieties of it, and compare those, contrast those, aggregate those data, we're going to learn a lot about the nature of the underlying biology of the disease, which I think will inform our approach to the larger populations of ALS. So again, to Stan's point and question earlier, why treat the nano-rare? It's because these lessons have, I think, very important implications to our understanding of the diseases that are more common, and we begin small and we grow.
Yeah, thank you. And this is a great example of, we definitely envision this model for other specific disease-focused partnerships as well. It really enables additional funding opportunities that we can really take and think, okay, specifically, how are we able to apply additional resource to this specific disease group? We can introduce even more efficiencies across the platform, even in the context of understanding each patient's individual phenotype and as it compares to others. And I think also, like you said, is we're already starting to see, so we have, I think, 15 patients with ALS already in our program. And those that come in with mutations, different mutations in the same gene, this enables us to learn and repeat and do it better and learn and be more efficient because we've looked at this gene before. And so that's really incredible. And also the learning about how these patients, even patients with the same mutation, I think what Stan touched on, one example this morning, how patients with same mutation still have different phenotypes. And that comes to the importance of really the need for individualized care. So Terry Jo, we'd love to hear a little bit from you. So a little bit more about COMBINEDBrain. I think you touched on in your introduction about knowledge sharing and education. And maybe you could expand on kind of your thoughts around that space and how can we work together to really, educate and inform patients and advocacy groups to come together to collaborate.
So COMBINEDBrain stands for Consortium for Outcome Measures and Biomarkers for Neurodevelopmental Disorders. So we're actually up to 100 disorders now.
Okay,
And
great.
we are trying to share ways of measuring treatment effect across all of those disorders. And I think that's how COMBINEDBrain can help n-Lorem. We can come up with ways to make the actual clinical trial aspects of it more efficient. So our clinical advisory board, Liz Berry-Kravis, they have all suggested that we create a closet of outcome measures that the clinicians, the primary care practitioners who we need to empower and educate could open the closet and pull out the outcome measures that are already validated that they can use to see if the treatment's helping. But I think we also have to really systematize ways for the individual to measure what matters to them. So you talked about how you have patients with the same mutation who have a totally different phenotype. You have to measure what matters to each patient. And so you have to do both. You have to have goal attainment scaling or individualized measures, and you have to have these validated measures from the closet. And then hopefully we can share that data across those measures and individualized outcomes and all of that so that we can make the kit an easier task for the next primary care doctor who comes along the pike. I think that's what COMBINEDBrain needs to do. Plus we need to help you find more patients.
Yeah.
And by doing that, I mean we need to get diagnostics earlier and earlier and earlier and get stem cells and other resources that can be used so that we can get the whole process to move faster.
Yeah, no, that makes a lot of sense, and we're really working to ensure the standardization across data sets, and it's such an important component. We'll hear more from Lori a little bit later about that. So I mean, we've talked a lot about identifying patients, so really the newborn sequencing, ultimately all of these ways, working with physicians. Kristen, I wanted to turn it back to you just with regards to some of the capacity building that we've talked about. And I wonder if you could speak to kind of some of the goals that St. Jude has as far as just thinking about even learning some of the processes that n-Lorem is doing for ASO discovery and development.
Sure. I think, from our perspective, it's really about collaborative research and thinking about how can we, across the board, with as many collaborations and engagements as possible, participate in research that becomes smarter and faster and scalable by working together. And I think that's part of what drew us to working with n-Lorem along with a lot of other stakeholders in the space, including some who are in the room here today. So for us, it's really about capacity building in terms of sharing insights, sharing learnings, sharing resources, sharing models, frameworks, processes. And so that really is kind of at the crux of the work that we're doing together and that we're wanting to do also quite broadly in the research space.
Yeah, no, thank you for that. It's really exciting. I think there are many different steps of our process, of course, that will bring different elements of the collaboration. And I think, I feel like even last night there were a handful of individuals that I spoke with and were like, we're really interested in doing this. And this is not only in the US, but more broadly speaking. So I guess I would love to hear, and maybe Neil, we could start with you, is just like if there's interest from perhaps an advocacy group or from an organization that's interested in trying to discover and develop ASOs, kind of what is your thoughts and what are your advice on even initiating this type of collaboration?
Yeah, well, I mean, there's been extraordinary interest in this. Our efforts in Silence ALS are focused really in the United States, but as I go around the world, people are coming to ask how we can do this in their country. We have the advantage, and I think we'll talk about this later, we have a regulatory path here in the US to do this. That path doesn't necessarily exist, but that's part of our mission, I think, which is to export this opportunity to other nations. And people wanted to get involved, and I think in panel's been touching on this. I mean, individual physicians, in order for this to succeed, you need dedicated scientists, clinicians, who are involved with the patients, involved with the families, doing the clinical phenotyping, not just at the point of nomination to n-Lorem, but in the months that it takes to get to a clinical ASO, and then beyond into treatment. I mean, this has to be a true partnership. We need dedicated clinicians, and what n-Lorem has to do, what Silence ALS is trying to do in our small corner, is to remove the impediments that are in place for clinicians who want to do this, because the interest is great, greater I think than we can accommodate, frankly, at the moment. But we need, as this scales, to remove the impediments for individual clinicians to do it, to provide them with the resources, the templates, the platform to make this easy, for them. When we did it with the first ASO, it felt very much like we were inventing the wheel. It's no longer the case, thanks to n-Lorem and thanks to Silence ALS, and I think this can be true for many diseases.
Yeah, it's a great point. And so really, it starts with the patients, it starts with the advocacy group, and having a very strong physician. I think we have a lot of amazing physicians that we're working with as well, but really that's a critical component, is having that really true partnership. So we just have a couple minutes left. I think before moving on to kind of the final question, I guess, Annalisa, would love to hear your perspective on, in let's say 3 years, when we're sitting here at the Colloquium, we will be in a very different place. I would love to hear from each of you, like what would you imagine, and where do you hope that we'll be able to be in that time?
So I would love it if patients in the NHS could have benefited from the drugs that you're developing. I think if we can treat the first patients, that will really help us to link up the ecosystem and drive forward these pathways to open it up. I think that it's really, it's key to show actionability, so linking again in with the newborn whole genome sequencing, the conditions that are included in this first pilot study are those that are actionable in early childhood, and I think having evidence for actionability is really going to be also key, driving forward the earlier and earlier diagnosis and treatment. Yeah. So I've probably leapt a bit further than 3 years there. But I think that the sort of paving the way, and that it's okay to feel uncomfortable if we are at the forefront of trying to drive change, that's okay. Yeah.
That is okay, right? It's where we want to be.
Yeah.
I actually love that, and I mean, I think I doubt the pace will be any slower than that. And if anything, I think even where n-Lorem has evolved to is, if we think we would have had 3 to 5 patients in 3 to 5 years, and here we are with 100. The need is so great, and I think it's going to be really exciting to be able to just really pave the way. So we're really excited about that. So Kristen, would love to hear your perspective on this question.
Sure. So in the immediate term, being able to point to collectively, kind of at a community level, a number of effective and measurable treatments that have done what we want them to do and what they hope they can do, and that beyond that have really generated data and insights to be able to apply to more patients and to larger populations, so that we can really think about how does this go from an individual focus to being a population focus of individuals. And I think that you'll hear that a lot today. We've already heard that a lot today. But I do think with a kind of, as an institution with a research aim, that's what we're always thinking about. And we're very hopeful and optimistic that what's happening now will land in that place in the immediate term.
Yeah, great. Okay, thanks, Neil.
Yeah, I mean, I would say that this, I think for most of us involved in this effort, these efforts, that there's no question, but this approach is going to be successful. In 3 years, we'll be sitting in a larger room with more grateful patients, with more stories that Stan's going to be telling of the success of these ASOs. And I think success will beget success, and that will draw, once you've proven this, I think it's already been proven, but once you prove it again and again as an effective therapeutic and research approach, we'll get buy-in from some of the stakeholders that were mentioned in the previous session, and insurers, federal research organizations, people who will understand that this is an effort worthy of investment, and I think that'll help us to scale.
That's awesome. Thank you. Terry Jo. I'll leave it to you.
I think in the next 3 years, what I'd really hope is that we can streamline the whole treatment process. So come up with satellite sites where people can go and get treatment and yet be able to still be treated by their local physician at home, because it's so complicated to be able to, I mean, you're at a big institution that's allowing you to do this, but a lot of other big institutions are really struggling with allowing n-Lorem to treat patients. And so n-Lorem has to work with really local physicians. I think that's complicated for everybody. So I'd really like 3 years from now for there to be a much more streamlined process. So a guy in Kentucky who's got a patient with KCNT1 mutation that would really benefit would be able to treat his patient with the ASO, but take care of his patient in Kentucky day to day, collect the data, put it back in the pile. I think that's what I would like.
That's awesome. Well, I hope we have all these notes taken, because we're going to come back to you in a couple of years. So I think the key takeaway, what I'd love for each of you to hear, is just that each partnership is unique. Each collaboration is unique. We're aligned on the mission, but ultimately we're looking to do different things with different types of groups. And so ultimately together we can help many more Nano-rare patients and do it in whatever way. So if there are interested parties, we absolutely would love to chat with you and look forward to the rest of the day. So thank you all. Appreciate it. We'll move on to the next.